A very good afternoon and salam sejahtera to everyone. I am Nur Adila Anwar, your Master of Ceremony today. Please allow me to conduct today's ceremony in English. On behalf of Faculty of Medicine, University Malaya, I would like to say thank you for virtually joining this inaugural lecture, which will be delivered by Professor Dr. Gan Shiaw from the Department of Medicine, Faculty of Medicine. Her lecture will begin shortly. For your information, this inaugural lecture is organized for professors in University Malaya to share their knowledge and thoughts in their respective expertise. Announcing the arrival of Yang Berusaha, Professor Dr. April Kamila Roslani, Dean of Faculty of Medicine, who will also be chairing the lecture, and arrival of Yang Berusaha, Professor Dr. Gan Shiaw. Everybody, please rise for National Anthem and University Malaya song. Please be seated. Distinguished guests, fellow professors, academicians, researchers, and all online audience, ladies and gentlemen, welcome to the inaugural lecture by Professor Dr. Gan Shiaw entitled The Evolutionary Tales of Hematology. Without further delay, I would like to invite Yang Berusaha, Professor Dr. April Kamila Roslani, to chair the lecture and introduce Yang Berusaha, Professor Dr. Gan Shiaw. Please welcome.
Thank you very much, Madam Chairperson. Very good afternoon, salam sejahtera and assalamualaikum to all of you who are with us today, in person or virtually. To the first inaugural lecture for the Faculty of Medicine of 2021. The human race has long held a fascination for blood, from mystical rituals, mythical creatures, to scientific innovations and medical interventions. Blood is not only essential for life, but has been central to the way we perceive and lead our lives. No wonder that T.S. Eliot used it as a metaphor for life itself when he said that the purpose of literature is to turn blood into ink. Our orator today, Professor Dr. Gan Shiaw, has made the study of blood her life's work. Professor Gan is a professor in the Internal Medicine Department with a specialty in clinical hematology. She graduated with honours from University of New South Wales in Australia, and upon obtaining the MRCP, she joined the University of Malaya in 1999 as an academic lecturer in clinical hematology. Interestingly, she also holds a master's degree in leadership and management for clinical medicine, and she has leveraged this into leadership roles such as heading and developing the Division of Clinical Hematology up until 2018, and currently as the Vice President of the Malaysian Society of Hematology. She has played a key role in shaping and leading the training of hematologists in Malaysia as Chair for the Training Committee for Clinical Hematology. She also currently holds the position of Chair for the Examinations Subcommittee and actively mentors undergraduate and postgraduate students, trainees, and doctorate students. As I mentioned before, her prime interest in research is in blood, or essentially the hematopoietic stem cell transplantation techniques, with an interest in lymphoma and myeloma. She is actively involved in multiple international clinical trials and scientific research, and has published numerous peer-reviewed research articles, and is often engaged as a speaker, chairperson, advisory board member for both regional and international events. So please join me in warmly welcoming Professor Gan Shiaw as she takes us through evolutionary tales of hematology. Professor Gan.
A very good afternoon to Professor Yang Brosa, Professor Dr. April. Thank you very much for your kind introduction. A very good afternoon to all who are watching this online, distinguished guests, my esteemed colleagues, friends, ladies and gentlemen. Indeed, this is a very disruptive period for all of us. Therefore, I'm very grateful and honored that you are able to join me on this occasion. The topic of my lecture today is the evolutionary tales of hematology. It's been a while since we last had an inaugural lecture on hematology, and I thought it would be appropriate for me to share with you some of the evolutionary tales of hematology. But first, what is hematology? To many non-medical people, hematology is not a field that they are familiar with. Some wonder if it involves only performing and interpreting blood results. Others think it is managing patients with blood-related infection or transfusion. In fact, both are not entirely complete nor inaccurate. Hematology is a field that includes many areas such as immunology, oncology, laboratory hematology, pathology, transfusion, and genetics. In this lecture, I would like to share with you how all these specialties have each played a crucial and significant role in clinical hematology, changing the treatment paradigm in many diseases. First, let me share with you some of the historical landmark discoveries which have made an impact in evolution of hematology. Dr. William Harvey, who was a royal physician, performed countless experiments, collecting data from phlebotomies and dissections of both human and animals to prove that his idea that blood indeed travels in a circuit in 1628. Subsequently, in 1671, Antony von Leeuwenhoek, a Dutch merchant and scientist, developed a microscope with higher magnification. He was first to describe red blood cells, although his description was not entirely correct. William Hewson, the father of hematology, discovered white cells and showed that it was fibrinogen that led to coagulation, paving the way for many others after him to understand the coagulation cascade. Dr. James Blunder, an obstetrician, performed successfully the first human-to-human blood transfusion in 1880 in a woman who suffered from postpartum hemorrhage. Of course, Dr. Paul Ehrlich, we know, a Nobel laureate, was instrumental in increasing the understanding of immune system. He believed in the idea of creating a chemical that would target only a specific type of germ or a specific type of tumor, and help develop the theoretical basis of chemotherapy. He also made other significant discoveries, whereby he found a new chemical which could stain bacteria and blood cells in 1877. This laid the foundation for further understanding of blood disorders and to an explosive growth in hematological investigation. Dr. Rudolf Virchow, as most of us are familiar with, as we learned about him, about Virchow note and Virchow triad in our medical textbook, he was the first person to recognize leukemia and also the first to explain the mechanism of venous thromboembolism. Dr. Karl Landsteiner, an Austrian-American immunologist, also known as the father of transfusion, identified the 3 blood groups in 1901 and won the Nobel Prize. His discovery made transfusion safe and a life-saving treatment for millions worldwide. During the 20th century, seminal discoveries in science continued to transform the art of diagnosis and treatment in hematology. The first case of sickle cell anemia was reported by Dr. James Herrick after he was alerted by his intern about sickle-looking cells in the blood film. 15 years later, Dr. Thomas Cooley, an American pediatric hematologist, reported a form of anemia among children from the Mediterranean region, and this was named as Cooley's anemia, later renamed as thalassemia. In 1953, Dr. James Watson and Dr. Francis Crick, who shared the Nobel Prize in medicine for discovering the structure of DNA, laid the cornerstone for Dr. Kary Mullis to invent polymerase chain reaction technique, PCR. This laboratory molecular technique has enabled scientists to generate thousands of copies of a DNA sequence rapidly and easily, since it has become an integral and indispensable part of clinical and diagnostic research, such as genetic, microbiology, forensic science, hematology, microbiology, and of course now very relevant, virology. Diseases in turn could be identified using specific mutation in the genetic code. This insight led to a better understanding into the pathogenesis of many hematological diseases, leading to the development of new drugs which target specific mutations. Consequently, the treatment paradigm for many hematological diseases radically changed, improving survival in patients. One of the most significant evolutionary tales is the series of landmark discoveries in chronic myeloid leukemia, where new knowledge of disease biology was translated into targeted therapies to revolutionize patient management and significantly improve outcome. Chronic myeloid leukemia is a type of clonal myeloproliferative neoplasm which is characterized by the presence of Philadelphia chromosome. It comprises approximately 15 to 20% of all adult leukemia. The median age of presentation is approximately 50 to 60 years of age. Patients usually present with splenomegaly and high white cell count. In general, the disease phases are chronic phase, accelerated, and blast crisis, which means leukemia transformation. In the past, the patient will maintain in chronic phase for approximately 5 to 6 years, but they will eventually progress to accelerated phase and blast crisis, whereby their survival will usually be never beyond 1 year. CML, or chronic myeloid disease, is disease of many firsts. It was the first leukemia to be recognized by Dr. Rudolf Virchow. It is also the first leukemia to be described in a medical journal. In 1960, CML was the first human cancer to be linked with a specific chromosomal abnormality. Dr. Novell and Dr. Hungerford described the recurrent chromosome abnormality in patients with CML, which they named as Philadelphia chromosome. In 1972, Dr. Janet Rowley discovered that Philadelphia chromosome was a result of the reciprocal translocation of chromosome 922. 10 years later, Dr. Grofen and Dr. Heisenkamp and colleagues demonstrated that unequivocally that BCL-ABL fusion gene is responsible for the pathogenesis of CML. In fact, this is the first fusion gene that is associated with cancer. In 1990, researchers identified the function of the BCL-ABL fusion gene. With the knowledge that it can be a potential therapeutic target, Dr. Brian Duker and his partners developed STI-571, the drug now known as imatinib or Gleevec, the first TKI or tyrosine kinase inhibitor which showed clinical activity against a fusion protein. Approximately 95% of patients with CML will have the presence of Philadelphia chromosome. It is a result from the reciprocal translocation of chromosome 922. This translocation juxtaposes the ABL oncogene on chromosome 9, you can see here, onto the breakpoint cluster region on chromosome 22, resulting in an expression of a chimeric protein or BCL-ABL1 fusion gene. The increased transcription of BCL-ABL protein results in an excessive amount of tyrosine kinase and phosphorylated protein that trigger multiple downstream signaling pathway, promoting cell proliferation, reduces cell adhesion, and suppresses apoptosis. So how does imatinib or tyrosine kinase work? As we know, tyrosine kinase is an important mediator of signaling cascade, determining cell proliferation and cell differentiation. So how imatinib works is that it binds to the amino acid of the BCL-ABL tyrosine kinase ATP binding site, thus blocking the ATP, preventing phosphorylation, and switch off the downstream signaling pathway which promote leukemogenesis. One of the landmark trials in CML is IRIS study, where 1,106 patients were recruited. Half of them were put on imatinib and the other half were put on interferon and low-dose cytarabine, which was the standard of care at that time. Patients were allowed to cross over. As you can see, the complete hematological response rate was significantly much higher than those who were put on interferon, 95% versus 55%. And the complete cytogenetic response was amazingly high at 76% versus 14.5%. Even after 10 years of follow-up, you could see the patient who were put on imatinib has a better survivor than those who were initially put on interferon and low-dose cytarabine. As you can see in this Kaplan-Meier curve, the survival of CML patient has significantly improved over the last few decades. The 10-year survival of CML patient was never beyond 20% in the 1980s. Treatment then were busulfan and hydroxyurea, but they were never curative. Even in the mid-1990s, when stem cell transplant was the only curative option, the 10-year survival was at best 60%. However, when imatinib was introduced, you could see that the overall survival has improved dramatically to be more than 80%. This is a beautiful example of how knowledge gained from basic science can lead to development of drug which is life-saving and revolutionize management. With this fantastic improvement of survival, milestone of optimal response also continued to evolve when monitoring techniques became more advanced. In the early part of CML treatment, complete hematological response was the goal of therapy, which means normalization of blood count and resolution of spleen size. However, in the mid-1980s, when stem cell transplantation was one of the treatment options, achieving complete cytogenetic response was then the desired target. And that means the bone marrow will have normal cytogenetics. When tyrosine kinase inhibitor was introduced, although complete cytogenetic response was the initial target, it was no longer the end point. More ambitious goal is set. We are now talking about even more sensitive method to detect even lower level of fusion protein. Monitoring tools switched from chromosomal analysis to PCR techniques. And now with the improved techniques such as the RT-PCR achieving major molecular response and deeper molecular response is now the target now. This is a figure to show how ambitious the therapeutic goal is now for patients with CML. It is no longer just 2 log reduction as seen here, but we are aiming now up to 4 log reduction. Measurement of B-cell ABL transcript level by quantitative reverse transcriptase PCR is now reported according to the international scale and has become the gold standard of monitoring. If patient achieves a major molecular response, which is a B-cell ABL level of less than 0.1% by the 12th month of tyrosine kinase inhibitor, it predicts a CML-specific survival of close to 100%. In summary, the continuous evolution of monitoring tools and strategy in CML are happening so fast, from blood counts to P-cell techniques. In future, one is studying even newer techniques such as digital PCR and next-generation sequencing to detect even deeper level of response at a shorter turnaround time. Newer generations such as nilotinib, dasatinib, ponatinib, bosutinib, which are more potent than imatinib, are also now available, and some can address issues of resistant mutation. Studies have demonstrated that these second-generation tyrosine kinase are able to induce significant better molecular response than imatinib. As you can see with nilotinib, the major molecular response is much better, similarly with dasatinib. And this led to approval as first line in some countries. Third-generation tyrosine kinase such as ponatinib is also available for patients who were resistant or intolerant to second-generation tyrosine kinase, and it is the only tyrosine kinase thus far which is approved for addressing a T315I mutation. So with this newer generation of TKI which are capable to induce deeper response earlier, the question for patients with CML is, can we stop TKI or tyrosine kinase inhibitor? These are some studies that has demonstrated that it is a possibility where 30 to 60% of patients remain in molecular response even after stopping treatment. There are now many clinical trials looking into this to identify which cohort of patients will benefit from this and what is the best tyrosine kinase inhibitor to start with and what should the monitoring strategy be. In University Malaya, and UMMC, we have also published our real-world experience of patients treated with imatinib, and the overall survival is comparable to what was reported elsewhere. In conclusion, you can see that CML treatment has evolved and patient survival have improved dramatically from the early 20th century when the disease was incurable to using hydroxyurea to control the disease to mid-1990s and 1980s when stem cell was able to cure a minority of patients, to year 2000s where CML became like a chronic disease with the introduction of tyrosine kinase inhibitor, and now 2020-2021 there may be a possibility that patient can stop treatment. I thought I would add another invaluable contribution by researchers and clinicians in hematology, that is hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation has evolved from being experimental in 1950s to the standard of care for many malignant and non-malignant hematological diseases, pioneering the concept of cancer immunotherapy. Just a brief note on hematopoietic stem cell or Hsct. They are found in the marrow and have the property of cell renewal and able to differentiate to all cell lines within the hematopoietic system. Nuclear bombing in World War II inspired research into the radiation effect on bone marrow, leading to a major breakthrough in bone marrow transplant. In 1956, the first successful bone marrow transplant was performed by Dr. Thomas in a leukemic patient from identical twin donor. He received a Nobel Prize for Medicine in 1990. Since the first successful bone marrow transplant, indication of transplantation has expanded and including immunodeficiency, aplastic anemia, and the numbers performed over the last 50 to 80 years has increased dramatically. Just a brief explanation, what is hematopoietic stem cell transplantation or Hsct? It is basically a procedure where the stem cells are given to the patient with the intention of repopulating and replacing the hematopoietic system in total or in part. Patient will usually be given chemotherapy with or without radiotherapy before the stem cell infusion. The rationale for the chemotherapy is to eradicate the underlying malignant clone and also to suppress the patient's immune system to prevent rejection of graft. There are generally two types of transplantation, autologous and allergenic. In autologous, the stem cells are derived from the patient themselves, whereas the allergenic is from a donor. The patient will use, in autologous stem cell transplantation, patient will usually have their stem cell collected earlier, and that will be then cryopreserved and stored, and patient will then undergo conditioning regimen, and then the stem cell will then be reinfused. Whereas in allergenic, the donor will have their stem cell collected either from peripheral blood or bone marrow. This will be processed, sometimes stored, but sometimes directly infused into the patient but after the patient have their conditioning regimen. You can see here, this patient is undergoing an autologous stem cell collection. This is an apheresis machine. This is performed in our transfusion medicine department in University Malaya Medical Center. The stem cells is usually stored in a liquid nitrogen tank, and when we need it, we will thaw it and reinfuse into the patient. There are generally three sources of stem cell: bone marrow, peripheral blood, and cord blood. You can see this is a bone marrow harvest where the patient or donor will undergo general anesthesia or spinal anesthesia, and the bone marrow is then being aspirated. The indication for stem cell transplantation in adults are mainly for malignant disease. In allogenic, the main indication are for patients with acute myeloid leukemia or acute lymphoblastic leukemia. Other malignant disease are myelodysplastic syndrome or lymphoma, which usually fail autologous transplantation. In autologous, the transplantation, the main indication are for multiple myeloma, lymphoma, and rarely we do in acute leukemia. As published recently, the number of stem cell transplant has increased dramatically over the last 10 to 20 years. Now it is increasing by more than 7% a year, and that equals to about 90,000 a year. And by end of 2016 and 2017, the total number of stem cell transplantation performed had approached 1.3 million. Survival has also significantly improved over the past 20 years. You could see here, if patient were to be transplanted in the early 2000s, the survival is significantly improved if they were transplanted in the year 2011 and 2017. This is similarly in patients with acute lymphoblastic leukemia as well. This is likely due to the advances of supportive care and better control of the disease prior to transplant. Similarly, the number of older patients being transplanted over the last 5 to 6 years is also increasing. You can see we are now transplanting patients beyond 60 years of age and even 70 years of age. This is partly again attributed to a better supportive care and the use of reduced intensity conditioning regimen. Although stem cell transplant has evolved and survival has improved over the years, there are still many challenges, and one of them are the lack of suitable donors. Only 30 to 35% of patients have an available HLA-matched siblings, and a large number of them face difficulty finding matched donor in international registry. Moreover, unrelated donor is also expensive, and there's always, usually there will be a delay in time. I'm going to show us a video to demonstrate the challenges that one will face looking for unrelated donor.
What would you do to save your child's life?
Yay! Congratulations. Oh,
I'll get a match.
okay. Don't mess up my desk.
I already got a match.
You are a smarty pants. Thank you. I am gonna get a picture. I know. Okay. Okay. 1, 2. Oh, it's Dr. Fisk. Just hold on.
Brenda?
Howdy! We are having our big celebration here. We got cake.
You get a dog bone.
Brenda, listen.
Here, hang on.
Fine. I'll eat it by myself. No.
No goofing around with that knife. Okay, doctor, I'm sorry.
I've got some tough news. The donors backed out.
No. No, they can't. They agreed.
But this happens more than you think. Maybe they'll change their mind, but we should start looking for another match.
But it took years to find this one.
We don't have a choice. Come by my office tomorrow. We'll talk through Taylor's options. Don't say anything to her just yet. A lot can change in a day.
You can continue watching the video at a later time if you want to. Therefore, over the recent years, alternative donors, such as haploidentical donors, have become a more common graft source. As you can see from this figure, a matched identical sibling is one who have the same HLA type. Can you see from this patient and the identical sibling? But there is only 25% that one would have a matched identical sibling, whereas haploidentical sibling, you can see, can have, as long as they have one similar, same HLA, they can be the donor, including the parents as well. Although there is advantages in the sense that the donor are very readily available and highly motivated, and one can proceed to transplant very quickly, there are also disadvantages such as graft-versus-host disease and graft failure. But nowadays, there are newer methods that we can actually reduce by the risk of graft-versus-host disease by manipulating the T-cell graft, for example, using post-transplant cyclophosphamide, as well as also identify donor-specific antigen to manage it accordingly in order for the transplant to be successful. According to the recent meta-analysis, haploidentical transplant and match-related transplant, the outcome are actually quite similar. Hence, more haploidentical transplantation are being performed over the last 5 to 6 years, as shown in this chart. You could see over the last 4 to 5 years in the orange line, the haploidentical transplant has increased. So let me share with you some of the history of hematopoietic stem cell transplantation in Malaysia and how it has evolved. The first bone marrow transplantation was performed by our pediatric team in University Malaya Medical Center, then called University Hospital, in 1987. The first adult bone marrow transplant was performed by the adult team in 1993. A year later, Hospital Kuala Lumpur, the Institute Pediatric, performed their first pediatric case. In 1997, the pediatric team of our hospital again performed the first cord blood transplantation. In 1999, the Ministry of Health Hospital performed their first adult bone marrow transplantation. At that time, it was at Hospital Kuala Lumpur. And the first bone marrow transplant was also performed in the private medical center, Subang Jaya Medical Center. In 2006, our hospital also performed the first match unrelated stem cell transplantation in adult. In 2012, the first haploidentical stem cell transplantation was performed in the Ministry of Health Hospital, then Ampang Hospital. The transplant activities have increased since year 1999 when Ministry of Health Hospital started performing stem cell transplantation. A total of 3,994 transplantation has been performed by end of 2016. According to the transplant registry published in 2016, the survival has also improved. UMMC performed the first bone marrow transplant in a young lady with acute myeloid leukemia in November 1993. The first adult match unrelated transplantation was in 2006. The young man was 17 years of age at that time, and after more than 14 years, he remained well and have since gotten married and currently working in Singapore. So let's change gear and talk about another innovative advancement of treatment of hematological cancer, immunotherapy. Further and deeper understanding of human immunology has grown exponentially in recent years. We tend to think that immunotherapy is a recent medical achievement, but in fact, it may have been dated back to as far as the 3rd century. As you can see in this timeline of evolution of immunotherapy, there are multiple breakthroughs throughout the last few years. However, it was in the late 1960, further understanding of the role of T and NK cells in cancer have propelled more research and development in cancer immunotherapy. One of the early immunotherapy is the monoclonal antibodies. It was Dr. Milstein and Dr. Kohler who pioneered the production of monoclonal antibodies in 1975 when they discovered method of generating monoclonal antibodies using hybridoma technology and won the Nobel Prize. This led to the development of the first successful chimeric monoclonal antibodies, and that is Rutuximab. It is a monoclonal antibodies with binding specificity to CD20. The monoclonal antibody causes lysis of the tumor by means of 3 major mechanisms: antibody-dependent cytotoxicity, cellular cytotoxicity, and complement-mediated cytotoxicity and apoptosis. It is now part of the routine treatment for most B-cell lymphoma. And it is also effective in autoimmune disease by reducing the adaptive immune response against self. The other breakthrough is immune checkpoint inhibitor, which is a type of monoclonal antibody which either target the cytotoxic T lymphocyte-associated protein 4 or the programmed cell death protein 1 pathway. It has become one of the most widely prescribed anti-cancer therapy for solid tumors. And these were developed by the 2 Nobel laureate, Dr. James Allison and Dr. Tasuku Honjo. In 1990s, Dr. Allison studied a protein on the surface of T cell called CTLA4, discovering that it inhibits the immune cells, demonstrated that antibodies against it can destroy cancer. In 2003, he tested it in patients with metastatic melanoma, with 3 out of 14 patients responded. In 2011, FDA approved ipilimumab as a treatment for late-stage melanoma. Around the same time in 1992, Dr. Honjo and his colleague identified another T-cell protein called PD-1. And in 2000, PD-L1, which is a protein found on the normal cell and cancer cells that binds to PD-1. And he demonstrated in 2002 that blocking PD-L1 halt the tumor in mice. In 2014, FDA approved the PD-1 checkpoint inhibitor pembrolizumab to treat melanoma. Immune checkpoint are normal part of our immune system. It regulates inflammation and immune response to ensure no overactivation of T cells and provide protection from hypersensitivity and autoimmunity. Cancer occurs when it escapes immunosurveillance. They do so by exploiting the immune checkpoint, for example, PD-1 or PD-L1. This immune checkpoint and partner protein bind together, sending an off signal to the T cell and preventing them from destroying the cancer. How immune checkpoint work is that it works by blocking the checkpoint protein, either the PD-L1 or PD-1 from binding their partner protein, and this prevent the off signal and allow the T cell to kill the cancer cells. As shown in this slide, the immune checkpoint inhibitor have been approved for many different types of cancer in many countries. The anti-PD-1 and anti-PD-L1 antibody are the most widely prescribed anti-cancer therapy and can be used in almost 50 cancer types. There are now more than 3,000 clinical trials, with 2/3 in oncology. In hematology, you could also see it is very effective in patients with Hodgkin lymphoma. In this swimmer's plot, you could see a significant reduction in the tumor size. Newer generation of therapeutic antibodies, such as bispecific monoclonal antibody, has also shown promising results in patients with hematological cancers. Bispecific antibodies combine the binding site of two monoclonal antibodies in one molecule and causes lysis of tumor, either by direct lysis of T cells or antibody-dependent cellular toxicity. One type of the bispecific monoclonal antibodies are the bispecific T cell engager, or BiTEs. BiTEs bind to the CD3 on the T cell and an antigen on the tumor, in this case a CD19. It will lead to the activation of T cells to kill the tumor cells. One example is blinatumomab, which was approved for relapsed refractory acute lymphoblastic leukemia in 2014 by the FDA. You could see that the survival of the patient on blinatumomab in acute lymphoblastic leukemia is significantly better in the first year. Just a picture to show how the T cell kill the cancer cells. You could see the orange line, the green line is a cancer cell, and this is a T cell. Another form of immunotherapy that is available in the market is the antibody-drug conjugates, or ADC. These ADCs comprise of a cytotoxic drug connected to a human or humanized or chimeric monoclonal antibodies via a chemical linker. It enables the cytotoxic agent to enter the cancer cells and causes cell death. The first approved ADC is gemtuzumab ozogamicin, which is treated for acute myeloid leukemia in 2001. And in 2011-2012, brentuximab vedotin was also approved for relapsed Hodgkin lymphoma. And now there are 3 more ADCs that are approved by FDA for hematological cancers. And many more are in the pipelines with promising results in patients with multiple myeloma and lymphoma. Of course, we can't go without talking about advancement in hematology without mentioning CAR T cell therapy, or chimeric antigen receptor T cell therapy. The feasibility and understanding that living cells can be infused into patients with leukemia for control of cancer, as in stem cell transplant, lay the foundation for developing CAR T cell therapy. Patient-owned cells are genetically engineered with synthetic receptor known as the chimeric antigen receptor in the laboratory, which are specific for a tumor antigen. This is then grown and expanded and reinfused into the patient. This table shows the history of development of CAR T cells therapy. This technology was first developed by Dr. Kajun and team from University of Pennsylvania and Children's Hospital in Philadelphia. The first published trial was actually in patients with chronic lymphocytic leukemia. However, the real success was seen in patients with acute lymphoblastic leukemia. The first child who received CAR T19 was Emily Whitehead in 2012, who was then 7 years old, and she had been referred to hospice due to the refractory nature of her leukemia. You can see she remained leukemia-free for the 8 years after infusion of the CAR T. As a result, research into T cell therapy is re-energized. Currently, CAR T therapy 19 have been approved for diffuse large B-cell lymphoma and acute lymphoblastic leukemia. Further clinical trials are also focusing in other hematological malignancies such as myeloma. Thus far, results have also been promising. New advances in CAR T therapy are also trying to create a next generation CAR T therapy, aiming to increase persistence of the CAR T, limiting toxicity, and also to enhance efficacy in solid tumor. Another possibility is to create CAR NK cell, which can be a potential source of allergenic off-the-shelf cellular therapy with anti-tumor effect. Over the recent year, the number of clinical trials involving CAR T and CAR NK cells have increased, with just over 110 clinical trials in year 2016, and 2 years later, there are now more than 600 clinical trials all over the world, mainly in the United States and China. This marks one of the major advancements in cancer treatment, which is targeted and personalized. So what does the future hold for clinical hematology? Gene therapy is another highly anticipated field which will likely change the paradigm treatment for hereditary hematological disorder in the future. Gene therapy offers potential cure for this patient by transferring a functional gene to replace the defective gene. One of the hematological disorders which are now being studied is transfusion-dependent beta thalassemia. Quite a number of clinical trials are being performed with results which are so far very promising. The other is in hemophilia A. As you can see in this paper that was published exactly a year ago, the result was very good, where patients have substantial reduction in the bleeding events and did not require any prophylactic use of factor VIII after gene therapy. Cure for this hematological disorder may become a reality soon. While the world was witnessing events such as discovering Philadelphia chromosome and the early successful bone marrow transplant, hematology services in Malaysia in the 1960s were still in its infancy. In University Malaya, the second Dean of Faculty of Medicine, Dato Professor Dr. Lau Kam Sing, who himself was trained as a laboratory hematologist, started the hematology services and introducing hematology into the medical curriculum. One of his mentees was Professor Dr. Menaka. She was instrumental in setting up the hematology laboratory together with a colleague in University of Malaya. The clinical hematology in University Malaya Medical Center was pioneered only in the early 1980s by the late Professor John J. Bosco. He had returned from training in Australia in 1979 and joined the Department of Pathology initially as a lecturer. Several years later, his desire to bring hematology to bedside prompted his decision to transfer to the Department of Medicine and form the clinical hematology specialty. Transfusion medicine at that time was also starting to develop. Mr. Lim, a senior technologist, was in charge of the transfusion in the 1970s until Prof. Menaka took over in 1978. It became a standalone department at University Malaya Medical Center in 1997 with helmed by the late Dr. Cynthia Lopez. I added this slide to show how small the Department of Medicine was in the early years. You would have recognized some of our senior professors, Dr. Prof. Kiao Go, Professor C.K. Liam, Professor S.P. Chan, and this is Dr. Alan Tay and Prof. John Bosco with Dr. Florence Wang as the head of department at that time. These are the pioneers of the adult clinical hematology in UMMC, Professor John Bosco, Dr. Alan Tay, and Dr. Leong Kinwa, who joined in 1993. Together, they manage patients with hematological disease in Menara Utama 12th floor. In 1992, Dr. Alan Tay went to St. Vincent Hospital to be trained under Dr. Kerry Atkinson. And he performed the first bone marrow transplant in adult bone marrow transplant in Malaysia. And you could see also here a transplant workshop that is organized by the University Hospital then for the pioneering nursing staff together with the Australian bone marrow transplant nurses. So my journey with UM started in 1999. I had just passed my MRCP examination and was wondering what I should be specializing in. It was Professor John Bosco who encouraged me to join clinical hematology. He even submitted the application form on my behalf. Many of the young hematologists may not know him, but those who know him, they will tell you that he is a very charismatic and kind doctor and also a dedicated doctor, a teacher. When 1999, I joined Department of Medicine with Dr. Alan Tay as my mentor. You can see he's here, all right. But unfortunately, in end of 1999, he left University Malaya for private practice. However, he returned as a visiting consultant, returning a few times a week just to show us around and to teach us and to guide us. Dr. Ng Soo Jin, who was a lecturer in the Department of Pathology then, who had also early on joined the private practice, also returned as a visiting consultant, training us, teaching us both the clinical and laboratory aspect of hematology. At that time, Dr. Goh Kim Mien and myself was holding the fort until early 2000s or mid 2000s. Dr. Shankar, Vijaya Shankar, now Dr. Vijaya Shankar joined us, and Dr. Haris Rahman, who returned from UK in 2004. And you could see Professor B here. He was a master medical officer at that time with Dr. Wahab. And our Puan Shanti, if you will know her, she's our chief pharmacist at that time, as well Joyce, and of course Dr. Yao, who was the laboratory hematologist before. These are the photos of our nursing staff in Ward 6TD in the early 2000s. In my earlier part of my journey as a clinical hematologist, Professor Emeritus Dr. Cheong Soon King provided me numerous opportunities to further enhance my training and knowledge. And one of them was arranging a short attachment for a few of us at University Nebraska Medical Center, Omaha in USA. There I had the opportunity to speak to some of the well-renowned lymphoma experts such as Professor James Armitage, and also an opportunity to visit the transplantation ward and to learn about transplantation. And it was also during that trip that I decided to write a bone marrow transplant guidebook for patients. In 2004, I decided to spend my sabbatical leave at Westmead Hospital, Australia. I did a clinical attachment with the transplant unit under Professor Ken Bradstock. It was an enlightening and great learning experience. It was also good to be back at Sydney and caught up with my uni mates. My best friend, Dr. Georgiana, who has always been so kind to me, even offered to me to stay with her throughout the attachment, and even acted as my driver, ferrying me to and fro to hospital. Thank you very much, my dear friend. This is a picture of Professor Ken Bradstock, Dr. Jeff Sze, and Dr. Kerry Atkinson, who came to KL to visit us as an invited speaker for Malaysian Society Hematology Scientific meeting at that time. We have the opportunity to show them around. My interest in transplantation had also led to a few publications with my team members and collaborators. I was also privileged enough to be invited as a speaker to the International Congress on Bone Marrow and Stem Cell Transplantation in 2007 at Riyadh, Saudi Arabia. It was an eye-opening trip, and I learned and gained insight how other countries implement their transplantation program. As time went on, the number of patients increased. The daycare clinics and infusion room, which were initially located on the 6th floor, were becoming too crowded. There was no privacy for patients and doctors. Nurses were struggling to provide care in a small and narrow space. The need to move to a new place is obvious. Through many years of planning and support from the hospital management, we finally moved to a new daycare area in 2nd floor Menara Timur at end of 2016. You can see it is much larger and more spacious. My journey in UM was not purely clinical. I was also introduced to basic clinical science research by several notable figures who had not only gave me permission to access to their lab and also showing me the how in lab research. The start of my exposure to basic science research began with Dr. Allen, who first suggested that I look into the possible reason why warfarin maintenance dose appear to be higher in patients of Indian ethnicity. So when our clinical observation was confirmed, we continued with the why. Professor Maud Phipps, now a professor of human genetics with Monash University, kindly showed me the rope back then, allowing me to use her lab, introducing me to Dr. Mike Lee from Academia Sinica, Taiwan for further collaboration. And it was there during the 2008, I also spent my, while pregnant with my son, I also went to Academia Sinica to do the laboratory work and hence the publication here. My interest in genetic polymorphism continued, collaborating with the pharmacology department, Professor Datin Zahurin, our PhD students Dan, who is now with IMR, Professor Vera from Department of Pathology, colleagues from Ministry of Health, as well as Dr. Ng Chin Ching from Faculty of Science. We also publish and look into some of the genetic polymorphism in patients with lymphoma. I have also the privilege to be part of the working committees for some of the national guidelines. Malaysian Society of Hematology has also played a significant role in my journey. The society provided me opportunity to meet many renowned experts, opportunities for collaboration, and instilled in me organization skills for planning events such as conference and workshops. And one of the person that I would like to mention is Dr. Vichalachi Purusottoman. We call her Dr. Puru. She was the mother of hematology in Malaysia. She co-founded the Malaysian Society of Hematology with Professor John Bosco. She was also the first who is instrumental in designing the training program for clinical hematology. Even though I am in the university, she was always very kind and always willing to provide guidance to me, and she wrote me in to the committee in the training committee. And with that, we also now have a very structured training program as well as exam assessment method assessment as well. The National Scientific meeting organized by Malaysian Society of Hematology also provided platform for many of us, including the allied healthcare profession, to present studies and share knowledge, and at the same time catching up with one another. These are some of the photos which I could find over the last 15 years or so. Not very good in keeping photos of myself, but these are conference trips with friends and colleagues who are always filled with abundance of knowledge as well as fun. In 2016, when I was wondering what I should do for my sabbatical leave, Professor Dr. Adiba introduced me to Professor Dr. Kichu Nair from University of Newcastle, and that's when I decided to take up a master program offered by the university. This program was first developed by Professor Kichu and Professor Chris when they saw the need to introduce hospital management and leadership skills for doctors who often are also administrators. It was a program where I learned much about the insights of hospital management, aspect of quality control, various education tools and assessment methods for medical officers and staff. Professor Kichu was also so kind that he requested the university management to offer me a local student rate rather than a foreign student rate. In fact, I was their first overseas student who enrolled in this program. The program widens my views and exposes me to various leadership skills. Early last year, I was also invited to help out in the program and was offered the position of Joint Adjunct Associate Professorship. I really wish to thank Professor Adiba and Professor Kichu for this opportunity. Since I have handed the headship of the clinical hematology to the capable hands of Professor B, I've been keeping myself busy with research involving myeloma and am now part of the Asian Myeloma Network member. We are also looking at some basic research in myeloma. So looking forward, hematology has certainly evolved very rapidly over the last few decades. The extent of knowledge obtained from research has increased the breadth and depth of our current understanding of blood, making it one of the most exciting fields in medicine. The future holds great promise, as evident by the determinations of scientists, clinical investigators, and physicians who work together to advance the hematological research and clinical care. As for me, I have also grown and evolved, I think, and I hope in time to come I can continue to make scientific contributions in hematology, internal medicine, mentoring future generations of doctors and clinical hematologists as best as I can. Finally, I would like to express my gratitude to the people who had shaped me one way or another during my academic journey. My mentor, my teachers, Dr. Ellen, Dr. Ng Soo Chin, Professor Cheong, Professor Menaka, my past and present colleagues, to my research collaborators, to my study coordinators, my student, master and PhD student, to my research assistant, to the Marrow team. Thank you very much from the bottom of my heart. I would also like to specifically thank the clinical hematology team and especially Dr. Noor Adila for agreeing to be the MC. And I would like to thank my team for being so dedicated, hardworking, and supportive. And of course, I would also like to thank the Department of Medicine, the past and present head, Professor Dr. K.L. Goh, Professor Dr. Wan Azman, Professor K.J. Goh, Professor Sanjeev, Professor Sharu, Professor Ida, for being supportive. To the staff in the department, thank you very much for all the assistance and tolerating my temper sometimes. To all the lecturers and MOs and students, a big thank you. I hope I wasn't too strict. To my ward and daycare nurses, a big thank you and hugs for bearing with me and being so committed to the care of the patients. To my patients, you have taught me invaluable lessons of life and resilience. Last but not least, my utmost appreciation to my parents who gave up so much in order for all their 5 children to have good education. If not for their sacrifice, we would not be where we are now. And of course, I'd like to thank my in-law, my late father-in-law, and my mother-in-law. I am very blessed to be part of the family. They have been a constant support, source of support, emotion, as well as food. Lastly, a huge hug and kisses to my 2 children and husband who have been extremely patient with me. They are my pillars of strength and joy. Finally, I leave a few quotes for all of us to ponder. Thank you, stay safe, and stay optimistic.
Thank you, Professor Dr. Gan Shiaw. Ladies and gentlemen, I would like to call Yang Berusaha, Professor Dr. April Kamila Roslani, back again to the stage to summarize and conclude today's inaugural lecture.
Thank you very much. I think for those of us who are not professional actors or actresses, you know, the difficulty of presenting to essentially a camera is extremely high, and so I want to congratulate Professor Gan for achieving this very well with an enlightening lecture. Professor Gan has led us on a journey, a very long journey, which has gone from the bench top with laboratory-based research, and that has ultimately led over the years to meaningful treatments for patients and giving many of them hope. But I think what she has also eloquently described is that the challenges don't stop with the discovery of the treatments. There then comes the challenge of bringing those treatments to the populace. And in a time in the early 1990s, I remember that time very well, the number of staff in our hospital was exceedingly small. There were certainly many single-person units, and so there you were trying to deliver and fight for the services that you needed to bring to your patients, while at the same time trying to hold up your end of the bargain in terms of performing world-class research with limited resources. So I look at your description of all your predecessors, and all the trials and tribulations that they have gone through and that you have gone through yourself. And, I am extremely and exceedingly grateful that you have stayed on to continue to provide those services for our patients and continue to push and strive for provision of the latest in treatments to our patients. And I must announce here that we are working very resolutely towards being perhaps the first provider of CAR T cell treatments in Malaysia, and that's something very exciting for us all to work through. So once again, join me in congratulating Professor Gan. I'm sure she will take us to even greater heights and also leave a legacy by continuing the mentorship as her mentors have done for her in the past. I'm sure she will give back to the next generations and leave us in a much better state in the years to come. So thank you very much and good evening. Assalamualaikum warahmatullahi wabarakatuh to all of you.
Thank you, Professor Dr. April Kamila Roslani for chairing this lecture today. And thank you, Professor Dr. Gan Jin for your fruitful session. Ladies and gentlemen, this concludes our event for today. I hope that you have greatly benefited from today's lecture. I would like to end the event today with a serangkap pantun, especially dedicated to Prof. Gan. Gan Jin nama diberi, sangat digeruni bagi yang tidak mengenali. Hadirnya bagaikan idola buat kami untuk terus menabur bakti dan jasa dan bakti. Once again, on behalf of Faculty of Medicine, University of Malaya, we thank everyone for your time and hopefully we'll be able to see each other again in the future events. Thank you.